This one. Test mic.
والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Ladies and gentlemen, dear colleague, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this scientific event, which is the 27th session of the IMC Family Medicine Club. And as you know, we have started this club 3 years ago, and alhamdulillah, continuously we are striving to continue providing the quality CME and quality continuous medical educations for all the staff who are physicians in primary care, family physician, even nurses and other aligned services that's related to the family medicine practice. Our intentions is to boost the quality of practice and to motivate our colleagues in primary care to go ahead with their competency towards the excellency of practice of medicine. And as you know, ladies and gentlemen, we are witnessing now a total transformations in our healthcare system in the kingdom that is really focusing on the importance of primary care as a point of entry for all the healthcare services. So any patients will get into the medical services, the point of entry will be a family physician and primary care. So that's why we are going to hold in a big responsibility, and we are going to shoulder the success that we have to be maintaining all the way through. So this sessions is with a partnership with Family Medicine and Community Society, Saudi Society for Family and Community Medicine. And I would like to thank on your behalf the GSK company for sponsoring this event. And we are really privileged to have a group of our guest speakers who are very unique. They are very specialized in the topic. And I'm sure today we are going to witness a lot of updates and a lot of ideas and hints, in facts and pearls in the practice that will sharpen our expertise and make our knowledge more sharp, bi'idhnillah. So as you know, today we are going to talk about the bronchial asthma, bridging the gap in asthma management in primary care. They always say that there is always a guidelines, but there is a real world practice of medicine. And in between them, there is a gap. And today, ladies and gentlemen, we are going to fill up the gap by having our guest speakers trying to enhance this kind of information that will match to some extent the guidelines and putting the guidelines in the real world practice, in the real world quality of practice that we have. So today, without any further ado, I would like to introduce our guest speaker today, Dr. Dania Khalil. Dr. Dania Khalil, she is a resident in family medicine, and we have been choosing the residency to be part of our faculty. Why? Because they are the people who are going to bridge the gap between those who are in the medical professions as family medicine and those who are still in the process of learning, so, and I'm very sure that the quality of our residents, alhamdulillah, they are very unique to the extent that they are almost a specialist and even sometimes a consultant by their profession. So Dr. Dania, she was graduated from King Abdulaziz University, and she had awarded the Certificate of Excellence in Medicine and Surgery from King Abdulaziz University. She has been identified to be a very unique physician, to always strive to do the best to enhance her skills and to promote herself to the level that she is expecting, and she is going to demonstrate part of her competency today. She started family medicine residency in the joint program of family medicine, and all the way through she had been demonstrated the competent family physicians, the committed, the responsible, and even the motivated family physicians. So Dr. Dania, she's going to have two sessions today. One session is to tell us about the approach of asthma in adults in primary healthcare and the management. And this is how we approach patients. When the patient comes to family medicine, they are raw patients. They are not yet encountered to somebody who can diagnose their case. So the first approach is to have the proper diagnosis and then to treat the patient. And as is stated elegantly by the American Academy of Family Physicians, they say the competent family physician can treat and diagnose 80% of the cases. So this is the bread and butter of our day-to-day practice is bronchial asthma, and I'm sure that Dr. Dania will highlight the importance of positioning ourselves in this kind of level of practice. And we work all the time in a harmony between the primary care and the secondary care in order to let the patient move smoothly across the spectrum of the healthcare system without any kind of turbulence. So we speak the same language of medicine, which is the guidelines that we have been assigned to be the way to go. So the second session will be a case study, which is going to be another interesting topic from the real world practice will be highlighted by Dr. Adania. Also, we have Dr. Faris Al-Hijairi, and I'm going to introduce him as they come, and Dr. Ragad Arif, and I would like to thank all of them, in fact, for accepting our invitations and being a part of this successful event. So Dr. Adania, I would like to welcome you here on the stage, and we are eager to learn and listen from you, inshallah. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for this opportunity to participate in this valuable conference. I am Daya Khalil, R1, Family Medicine Resident in the International Medical Center. Today, inshallah, we will talk about the asthma diagnosis and management. And then at the end of the presentation, we will move to the case, inshallah. First of all, we will start by defining the asthma. Asthma is a heterogeneous disease, commonly affect 339 million worldwide, characterized by chronic airway inflammation. Potentially, it's serious. Symptoms include chest tightness, wheezing, cough, shortness of breath. It varies in frequency and intensity with variable expiratory airflow limitation. Then we will move to the pathophysiology of the asthma. Asthma has, first of all, it has infiltration of the inflammatory cells, which are eosinophils. It will lead to mucus gland hyperplasia, leading to mucus plugs, goblet cell hyperplasia, and thickening of the basement membrane and increased smooth muscle mass. Regarding the mechanism of the asthma inflammation, which is chronic eosinophilic bronchitis, along with the airway hyperresponsiveness, it will be provided by the triggers, allergens, exercise, cold air, SO2 particulates. All of them will lead to the asthma symptoms, which are cough, wheezing, chest tightness, and dyspnea. This is the normal airway of the normal patient which doesn't have asthma, and in the right side, the airway of the patient who has asthma attack. Although evidence-based treatment is available in most countries, asthma control remains suboptimal, and asthma-related deaths remain a major concern. Suboptimal asthma control is in 56% of patients. It's associated with poorer asthma-related quality of life, high risk of exacerbations, and greater consumption of healthcare resources. Variables associated with suboptimal control were age, gender, obesity, smoking, and comorbidities. 8 out of 10 patients believe their asthma is well controlled, but actually in reality, 45% were uncontrolled. What are the reasons of poor asthma control? The wrong diagnosis, comorbid conditions, exposure to allergens, poor inhaler technique and incorrect choice of inhaler, adherence of the patient to the medication and patient beliefs, individual variation in treatment response and under treatment. This is the algorithm of asthma diagnosis regarding to GINA guidelines. First of all, patient who is coming with respiratory symptom, we will ask the first question, are the symptoms typical for asthma diagnosis? If yes, we will dig more in the history and do physical examination to confirm the diagnosis. If no, further history and test to alternative diagnosis should be done. If alternative diagnosis is confirmed, we will treat for alternative diagnosis. If after history and examination, the history support asthma diagnosis, we will ask other question, which is the patient already taking asthma controller treatment? If yes, we will go to the table which is telling us the steps of diagnosing patient who is already on controller treatment. If no, we will perform spirometry with reversibility test. If the results support asthma diagnosis, we will treat for asthma. If no, we will arrange for other tests, and if the other tests confirm asthma diagnosis, we will treat for asthma. If will not confirm asthma diagnosis, we will consider trial of treatment for most likely diagnosis or refer for further investigations. This is the table which is showing the steps of confirming the diagnosis of asthma in patient already taking ICS containing treatment. First of all, if the patient has variable respiratory symptoms and variable airflow limitation, this will confirm the asthma diagnosis. And if the patient has variable respiratory symptom but no variable airflow limitation, we will consider repeating spirometry, but we should withhold the bronchodilator 4 hours for SABA, 24 hours for twice daily ICS LABA, and 36 hours for once daily ICS LABA, or during symptoms. If the patient has fewer respiratory symptoms, normal lung function, and no variable airflow limitation, we will consider bronchodilator responsiveness test, again, after withholding the bronchodilator as above during the symptoms. If normal, we should consider alternative diagnosis. Considering stepping down ICS containing treatment, when to consider if symptoms emerge and lung function falls, asthma is confirmed. If no change in symptoms or lung function at lowest controller step, consider ceasing ICS containing treatment and monitor patient closely for at least 12 months. If the patient has persistent shortness of breath and persistent airflow limitation, we should consider stepping up the ICS containing treatment for 3 months, then reassess the symptoms and lung function. If no response, we should resume previous treatment and refer patient for diagnosis and investigation, and we should consider asthma COPD overlap. This is the diagnostic criteria for asthma in adults, adolescents, and children 6 to 11 years. First of all, we should start with the history. The history should include typical variable respiratory symptoms, which are wheezing, shortness of breath, chest tightness, and cough. The second one is confirmed variable expiratory airflow limitation. First, documented excessive variability in lung function, one or more of the following: positive bronchodilator responsiveness reversibility test, or excessive variability in twice daily peak expiratory flow over 2 weeks, or increased in lung function after 4 weeks of treatment, or positive exercise challenge test, or positive bronchial challenge test, or excessive variation in lung function between visits, and documented expiratory airflow limitation. Asthma diagnosis. A diagnosis of asthma can be confirmed by assessing expiratory airflow limitation with spirometry and peak expiratory flow rates. A low FEV1 percent predicted identifies patient at risk of asthma exacerbation, independent of the symptoms, especially if FEV1 less than 60% predicted. Is a risk factor of lung function decline independent of symptoms level. A normal or high FEV1 in a patient with frequent respiratory symptoms prompt consideration of alternative diagnosis. Sorry. Peak flow meter. We have 3 categories. First is the green zone, which is 80 to 100% of personal best, which showed good control of the symptoms, and yellow zone, 50 to 80% of personal best. It means that the patient should be cautious, and the red zone is less than 50% of personal best, which is the danger zone. We can start an action plan based on the peak expiratory flow rate. Assessing a patient with asthma, we should assess the risk factors, assess the control by the risk factors and the comorbidities and the treatment issues. This table showed the assessing asthma control in youths greater than or equal to 12 years of age and adults, and it showed the classification of asthma control by 2 components, which are the impairment and the risk. First thing, we should ask about the symptoms. If the symptoms are less than 2 days per week, or less than 2, if our night symptoms or night awakening less than 2 times per month, the interference with normal activity, no interference with normal activity, and using of SABA less than 2 days per week, and if FEV1 or peak flow more than 80% predicted or personal best, this showed the well-controlled classification. The other one is the not well controlled, which showed the symptoms which are the symptoms more than 2 days per week, the nighttime awakening 1 to 3 times per week, and interference with normal activity. There is some limitations. Using of SABA more than 2 times per week, and FEV1 or peak flow 60 to 80% predicted. And the very poorly controlled asthma, the symptoms will be throughout the day. The nighttime awakening will be more than 4 times a week. The interference with normal activity will be extremely limited. The using of SABA will be more than several times per day. And the FEV1 or peak flow less than 60% predicted. And there are validated questionnaires for assessing the asthma control, which are the Asthma Therapy Assessment Questionnaire and Asthma Control Questionnaire and Asthma Control Test. And we should assess also the risk factors of exacerbation. If the exacerbations are 0 to 1 per year, this we will consider it a well-controlled asthma. If more than this, it will be not controlled asthma. And progressive loss of lung function and treatment-related adverse effects. The management of asthma include asthma medications, treatment of modifiable risk factors and comorbidities, non-pharmacologic therapies and strategies, and follow-up. What are the aims of chronic asthma management? The aims are we have to improve control and reduce the risk. Improve control of quality of life, improve functional status, normalize lung function, and control the symptoms, day, night, and activity, and reduce the risk of death and asthma attacks and unscheduled emergency care, and minimize the treatment side effects. The non-pharmacologic strategies of treatment include smoking cessation, exercise, healthy diet, weight loss, breathing exercise, avoid occupational exposure, avoid medication that trigger asthma attack, avoid allergen and pollutants. Management of asthma should also include patient education, which include the inhaler skills, adherence of medication, written asthma action plan, self-monitoring of symptoms and peak flow, and regular medical review. The written asthma action plan should include the patient usual asthma medication, when and how to increase medication and start oral corticosteroids, and how to access medical care if symptoms fail to respond. This is an example of asthma action plan. This is the form that we should give it to the patient. It includes 3 zones. The first one is the green zone, which also known as the safety zone. It includes the symptoms. There's no symptoms, or he is breathing easily, no cough or wheeze, can do usual activity, can sleep throughout the night. And the yellow zone, which also known as caution zone, the symptoms will be shortness of breath, cough, wheezing, chest tightness, some difficulty doing usual activities, sleep disturbance, and symptoms of cold or flu. The red zone, which should prompt immediate go to the ER or calling 911, which also called danger zone. The symptoms will be severe, and patient has breathing problems, cannot do usual activities, difficulty walking or talking, and rescue medications is not helping. This is the stepwise approach of patient diagnosed with asthma. First of all, after we start the management, we should assess the patient and confirm the diagnosis, and assessment of symptoms control, modifiable risk factors, assessment of comorbidities, inhaler technique and adherence, and patient preferences and goals. If the patient has symptoms twice a month or more, if the patient doesn't have symptoms, we should mark him in the step 1, which is as needed only low dose ICS formoterol. And if the patient has symptoms twice a month or more, this is the preferred track, which is track 1. Sorry. In step 1, we have the track 2, which is take low dose ICS whenever SABA is taken. At the same time, in combination or immediately after the SABA. Or in the step 2, the patient will have symptoms twice a month or more. The track 1 include as needed only low dose ICS formoterol, and track 2 include low dose ICS plus as needed SABA, or ICS SABA combination. If the patient has symptoms most days or waking at night once a week or more, patient will be categorized at step 3. In track 1, he should take low-dose ICS formoterol maintenance and reliever, which is MART, maintenance and reliever therapy. And if the patient will go to the track 2, he will have low-dose ICS LABA and as-needed SABA or ICS SABA combination. If the patient has daily symptoms, waking at night once a week or more, and low lung function, in the track 1 patient should receive medium dose ICS formoterol maintenance and reliever, And in track 2, patient should have medium or medium to high dose ICS LABA and as needed SABA or ICS SABA combination. In step 4 and more, short courses of oral corticosteroid may also be needed for patients presenting with severely uncontrolled asthma. This is the same algorithm, but it's separated. And this one include other controller options in the last of the page, which are low dose ICS whenever SABA taken in step 2, or daily leukotriene receptor antagonist. In step 3, we have medium dose ICS or adding leukotriene receptor antagonist. And in step 4, we have adding LAMA or leukotriene receptor antagonist. In step 5, adding azithromycin in adults or leukotriene receptor antagonist. As a last resort, consider low-dose oral corticosteroid, but consider side effects. This is not a preferred treatment for asthma patients. Before starting controller treatment, we should confirming the diagnosis and make sure that it's a correct diagnosis, because it's difficult to reach in 25 to 30% of patients. Document risk factors, assess the lung function, train the patient to use inhaler correctly, and schedule follow-up visit. ICS-containing treatment should be initiated as soon as diagnosis of asthma is made. If the initial presentation with severe uncontrolled symptoms or with an acute exacerbation, give a short course of oral corticosteroid and start regular controller treatment, which is ICS LABA. Follow up and review the response. We should review the response after 2 to 3 months. And reviewing ongoing treatment and other management issues, patients should be seen 1 to 3 months after initiating treatment, every 3 to 12 months after that, except in pregnancy. After an exacerbation, a follow-up visit should be scheduled within 1 week. Stepping up asthma treatment. Sustained step up if symptoms and or exacerbation persist despite 2 to 3 months of controller treatment. Before step up treatment, assess the following: the incorrect inhaler technique, poor adherence, modifiable risk factors, comorbid conditions, and short-term step up 1 to 2 weeks during viral infections or allergen exposures. Stepping down asthma treatment. Consider stepping down asthma treatment once asthma control has been achieved for 3 months to find lowest treatment that controls both symptoms and exacerbations and minimize the side effects. What are the changes in asthma management? GINA guidelines no longer recommends treatment with SABA alone. Because it increases the risk of severe exacerbations and that adding any ICS significantly reduces the risk. All adults with asthma should receive either symptoms-driven or daily low-dose ICS containing reliever to reduce the risk of exacerbations. This is a study which showed over-reliance on SABA and underuse of ICS are both associated with an increase in mortality. What are the risks of mild asthma? Patients with apparently mild asthma are still at risk of serious adverse events. 30 to 37% of adults with acute asthma and 16% of patients with near-fatal asthma, 15 to 27% of adults dying of asthma had symptoms less than weekly in previous 3 months. Exacerbation triggers are unpredictable, like viruses, pollens, pollution, poor adherence. Even 4 to 5 oral corticosteroids courses increase the risk of osteoporosis, diabetes, and cataract. Why patients like SABA-only treatment? Because SABA is an old treatment, and it has been first-line treatment for asthma for more than 50 years. And the patient satisfaction with and reliance on SABA is reinforced by its rapid relief of symptoms, its prominence in emergency department and hospital management of exacerbations, and low cost. Patients commonly believe that my reliever gives me control over my asthma, and they don't see the need of additional treatment. What are the risks of SABA-only treatment? Regular and frequent SABA use is associated with adverse events like it causes receptor downregulation, decreased bronchoconstriction, bronchoprotection, rebound hyperresponsiveness, decreased bronchodilator response, and it increased allergic response and eosinophilic airway inflammation. Dispensing more than 3 canisters per year is associated with higher risk of emergency department presentation, and dispensing more than 12 canisters per year is associated with higher risk of death. Take-home messages: SABA is no longer recommended as only treatment. All adults and adolescents with asthma should receive ICS-containing controller treatment to reduce the risk of serious exacerbation and control symptoms. Thank you.
Thank you so much, Dr. Dania. I know it was a very short notice to get you into this. Dr. Hibab apologized because of emergency she had, so that's why we couldn't manage getting, and thank you, Dr. Dania. She volunteered, in fact, and she demonstrated that we have a competent residents that they are going to carry the future of family medicine with a full confidence towards the excellence, inshallah. And now I would like to invite our guest speaker, Dr. Ragad Arif, and we are really very privileged to have her with us here today. Dr. Ragad, she is a consultant of internal medicine and respiratory medicine. She's a consultant of pulmonology and hypertension at King Abdulaziz University in Jeddah, Saudi Arabia, adjunct MD at Western University, London, Ontario, Canada, clinical and research fellowship in pulmonary hypertension, and FRCPC certified pulmonologist and internal medicine. And she has been involved as a speaker in many local and international conferences with a lot of publications. So Dr. Ragad, she's going to shed a light on the key recommendations for primary care from the 2022 GINA guidelines. So I'm sure this is another interesting topic by a very competent pulmonologist. So they are going to put the things in its own perspective from the primary care point of view. So thank you, Dr. Ragad, and I would like to leave the floor for you.
Assalamu alaikum warahmatullahi wabarakatuh. First, I would like to thank Dr. Ashraf for having me today. It's my great pleasure to be here on speaking to the family physicians and the primary care physicians. As we know, primary care physicians are actually carry an important role in the healthcare system, as they are the primary team to see the patient and to manage the patient, diagnose the patient, and initiate the appropriate referrals. So my job today actually to talk about the recommendation and update for the primary care from the GINA 2022. Actually, they are on the process of releasing the document of the GINA 2023. Not a lot of changes has happened between 21 and 22, but we will touch on these changes on today's presentation. Before I jump to the GINA treatment or the update in the GINA, I just want to talk quickly about the prevalence of asthma. So why asthma is still a big issue here in Saudi Arabia, and actually globally and nationally, asthma still is common disease and the prevalence is high. And this is a study was published a long time ago, actually 2018, and it shows the prevalence of the asthma based on the city. And if you can see in Jeddah, I think, yeah. It's difficult to show. So in Jeddah, you can see from 1992, prevalence was up to 10%, and then in 2014, we're reaching 21% prevalence of asthma. This is another survey was done, and this is a national survey conducted in Saudi Arabia 2013. It was a cross-sectional study where they actually looked at more than 10,000 individuals aged more than 15 years. And you can see the prevalence was reported at that time that only 4% prevalence of asthma in the country. And of course, that is not true. There was no difference between male and female gender. They also looked at some of the risk of exacerbation, bringing patient to the emergency department or hospital admission, and it was actually exposure to smoking, especially secondhand smoking and obesity as well. This is a more recent study, comes from our Saudi Medical Journal. This is a group from Riyadh that actually did the same thing. They did a questionnaire for patient, and it was involved more than 5,000 patients, and they looked at the prevalence of asthma by asking the patient simple questions. And they found that patients have wheezing in the last 12 months were more than 18% without a cold. So 18% of patients, they have wheezing without even getting sick with a cold. And there was no difference between male and female. That's a lot. 11%, they were giving a diagnosis of asthma by physicians. So it's not 4%. Now we're talking about 10% of our population asthmatic. And the prevalence of patients taking asthma medication was also up to 10%. Okay, and there was no geographical difference between the area in the country. Again, more recent study was published in 2021, and this time they interviewed about 8,000 individuals around 20 regions in Saudi, and applying a questionnaire from March to April 2019. And what we get, overall prevalence of wheezing in the last 12 months was about 14%, and 38% they have symptoms of severe asthma. So this is concerning. Asthma is growing, symptoms is growing, and more severe asthma is growing in the country. Not a lot of patients have diagnosis by physician, only 83%, and 38% of them have only action asthma plan. So they are more severe patient, more severe symptoms with no clear plan for management. Women were more common to have wheezing, and some of the statistical significance that was associated with the wheezing and presence of wheezing was certain type of jobs, exposure to smoking, and also exposure to heating the house after when it's cold. So another epidemiology study did show that we're not sure about how much prevalence of atopy that we have in the country. And we can see from our clinic, I'm sure, primary healthcare clinic and internal medicine pulmonary clinic, we have a lot of atopy. Patients describe a lot of atopy, they're highly atopic. In the previous epidemiology study, that said it reached more than 60% of our asthmatic patients, they have atopy, and asthma considered to be ranking 19th in terms of disability adjusted life year. So what about the morbidity and mortality? You can see emergency visit. We are 5 times more than Europe for our patient to go to the emergency department. We're more than 3 times than Europe for our patient to get hospitalized. And again, that's a global condition. That's not just in Saudi Arabia. It's a disease that has still higher prevalence. There was more than almost 400,000 deaths happened in 2015 from asthma, growing morbidity and mortality, growing uncontrolled percentage of patients with uncontrolled symptoms. So why do we care? Why do we care about patients if they are uncontrolled and they're having severe asthma? We care because they carry higher morbidity and mortality and carry higher burden to patient himself, to the community, and to the hospital as well. They can present with recurrent exacerbation, present to the emergency department and hospital. They can use a lot of oral corticosteroid and have side effects. They can have reduced lung function and poor quality of life, and also they can have type 2 inflammation comorbidities. Again, patients, if they are uncontrolled and severe, they have high burdens of having other conditions, as you can see, that can make the patient quality of life even worse. So It's high disease with higher burden. So let's talk about what's the difference between uncontrolled and severe asthma. So what is the uncontrolled asthma? So this is the symptoms is still not under control and patient can have flares or exacerbation. However, these patients can have mild asthma, although guidelines doesn't like this term, but they can have mild asthma and the asthma could be well controlled if they are adherent to their puffer, but they're not. Difficult to treat asthma is not a difficult patient. It's actually asthma that despite being on treatment, they're still symptomatic because of other contributing factors, other issues. Could be incorrect techniques or poor adherence or poor presence of comorbidities. More definitions comes toward the severe asthma when you still have patient uncontrolled having exacerbation despite dealing with all these contributory factors and patient in high doses medication. So these are the factors that you look at when you have somebody has an uncontrolled persistent symptoms. Look at how would you know that this patient is uncontrolled? What are the criteria? Poor symptoms control, serious exacerbation required hospitalization, ICU, more than two exacerbation require oral corticosteroid or declined lung function. All this tells you that your patient having persistent symptoms are not doing well. Okay, so what's our job? Our job as primary health cares, physicians, as pulmonologists, internists, that we need to look at the risk factor. Okay, not all of these patients have severe asthma. Most of them, they actually have mild asthma, but the asthma is poorly controlled. And you can see at some of the factors here, some of them, they're related to the patient himself, the disease, over-perception of their control of the symptoms, or underestimation the severity of the disease. Also present of some socioeconomic issues where the patient, for example, cannot afford the puffers. How about the clinician? The clinician underestimate the condition, underestimate the severity of the asthma, or overestimate the control of the asthma, and sometimes could be incorrect diagnosis or incorrect regimen. How about exposure? It could be smoking, environmental exposures. How about comorbidities, obesity, GERD, chronic rhinosinusitis issues, multiple allergies, presence of depression and anxiety. All these comorbidities will make the asthma difficult to control. Sometimes medication, so the patient can use NSAID, aspirin, beta blocker. They can have suboptimal use of their medication. All these factors, some of them are modifiable, some of them are not modifiable, and all make the asthma symptoms poorly controlled and increase the patient risk of exacerbation. This is a very nice diagram showing you the proportion of patients having severe asthma. So you can see 24% of patients in high intensity regimen. What does that mean? They're in high dose ICS/LABA, or they are in medium dose ICS/LABA with oral corticosteroid. All of them, they don't have severe asthma. Most of them, they have mild asthma. But what if you bring them and check their symptoms, they have poor controlled symptoms. 17% of them, they have difficult to treat asthma. It's not severe asthma. It's an asthma that difficult to treat because of comorbidities, because of risk factor, because of other issues that basically make their asthma difficult to control. If we treat these people, dealt with the risk factor, dealt with the comorbidities, dealt with inhaler issues and adherence, only 3.7% of your patient have severe asthma. So only 3.7% of our patients with severe asthma land on the high GINA guidelines management for step 4 and step 5. The rest, just we need to treat them better and improve awareness and improve teaching to the patient. How about atopy? We all hear about type 2 inflammation asthma, and Dr. Dania did mention about this in her talk. So 50-70% of our patients actually atopic and have type 2 inflammation asthma. How do we know them? They are atopic, they're allergic, they have allergic rhinitis, allergic conjunctivitis, atopic dermatitis, food drug allergies, they have multiple allergies. They are early symptoms to have high level of IgE in blood if you tested. They have higher eosinophil in blood, and they are very responsive to steroid when they use it. So we know 70% can be type 2 inflammation asthma. So this is type 2 inflammation asthma. Danny did show this patient have remodeling of the airway, mucus plugging, inflammation, smooth muscle tightness. That will lead to airway narrowing. And then what's the outcome? Exacerbation, reduced lung function, worsening symptoms, poor quality of life, and airway hyperresponsiveness. So type 2 inflammation also can be associated with other comorbidities. As you can see, food allergy, esophagitis, atopic dermatitis. 80% of our patients have allergic rhinitis. Chronic rhinosinusitis with or without nasal polyposis account for more than 30% of our patients. NSAID, aspirin, also respiratory disease. So all these type 2 comorbidities can co-present with the asthma, making the asthma more difficult to control and increasing risk of persistent symptoms and further increase the disease burden. So what did the GINA then tells you, the GINA guidelines? The GINA guidelines tells you that we have 2 tracks that we need to follow in treating patients with asthma. And I think everybody did actually look at that at this track. And track 1 is basically focused into using fixed dose of ICS formoterol as a reliever therapy. 2 cohort of patient, same lung function, same symptoms control. The group A, you give fixed dose ICS LABA as a reliever therapy. Group B, you give SABA as a reliever therapy. Which one will do better? The studies did show that patient on SABA alone, without ICS in their system, they will have more risk of severe exacerbation. This is why we go for track 1. Okay, how about track 2? You can use track 2. It's not equal to track 1. It's less favorable than track 1. Less effective. Why? Because in track 2, if you are not sure that your patient will be adherent to the therapy, will be using ICS alone as a treatment and using SABA as needed, you're going to subject your patient to using SABA alone, which is the same issue. So you have to make sure before choosing track 2 that your patient is actually have good adherence and patient did not have exacerbation in the last 12 months. So let's look at this. So when we approach the GINA guidelines, so again, we don't just step up and step down medication, we go through an approach. This approach starts by assess the blue. We assess diagnosis. We assess symptoms. We modify risk factor. We assess comorbidities. We consult sometimes ENT, allergy, immunology, gastroenterologist to help us treating of cases of difficult to control asthma. We check inhaler techniques. We teach, and we basically check the adherence of the patient. And then we modify the treatment with non-pharmacological and pharmacological treatment, and we educate, and then we reassess. So we review our response. We review our response based on symptoms, exacerbation, lung function, and patient satisfaction. Let's go to track 1. So that's the preferable track, and you have step 1, 2, 3, 4, 5. The earlier steps are the patient with less symptoms and less persisting symptom of asthma. As you can see, what is the reliever in the track 1? Fixed dose ICS formoterol. So you need to give them reliever. So in early stages, step 1 and 2, you're only giving a reliever. For example, budesonide formoterol. You're going to say to the patient, just use it as needed when you have symptoms in early stage. However, when you go to step 3, you start using ICS formoterol as needed and fixed doses as well as low dose. So what is this? MART therapy. We all hear about MART, maintenance and reliever therapy. Single inhaler, use it as needed and use it as a fixed dose. Okay? When you go to step 4 and above, you're going to increase the doses, and in the last step 5, you can add LAMA. So when you add LAMA at step 5, your patient on triple inhaler therapy, ICS, LABA, and LAMA. So that's the preferable track all the time. What is the reliever? What the patient uses if he has symptoms, he will use the reliever of ICS formoterol. Okay, very effective pathway, very good pathway. Okay, alternative pathway, less effective, especially in the early step 1, step 2, because you're going to give the patient reliever of SABA. He's not using ICS formoterol, he's using SABA. So your patient will use SABA, and you're going to tell him, somebody have symptoms less than twice a month, please take the other inhaler of ICS and use it whenever you use your SABA. What is he going to do? Use the SABA alone. Okay, again, step 2. You're going to give him a low dose ICS, one of the inhaler with fluticasone alone, or just piclamethasone alone. And you're going to say, use this every day. And if you have symptoms, use the SABA. What is your patient going to do? Use the SABA alone. So it's going to subject your patient to using SABA alone. So the risk of the track 2, unless you have highly adherent patient who have no exacerbation in the last 12 months, will subject the patient in using SABA alone. The last track is basically less effective track, and this is the tracks when we asked about the role of the leukotriene inhibitors, Mintelocast, Singular, the use of house dust mite-related sublingual immunotherapy. This is not as effective as track 1 or track 2, so we don't use it often because we know it's not equal. So why? Danny already showed this mild asthma. As we said, people have very similar symptoms less than weekly, higher risk of near fatal asthma, 15 to 20% dying of asthma, So mild asthma doesn't mean the asthma. Research and guidelines don't suggest even that you should say mild asthma. As Dania said, triggers are usually unpredictable, and using OCS actually less than 3, not even 4 to 5. 3 times you give them oral steroid per year, they're at risk of diabetes, cataract, and hypertension. So we know that regular use of SABA is not good, and this is why the guidelines in the GINA 2019 had the fundamental change that we don't use SABA alone as treatment of mild asthma, not anymore. This is risky, this can increase risk of severe exacerbation. And again, if you describe your patient SABA, أول ما يجينا للعيادة, your patient will think that's the treatment of asthma. He will feel a little bit relieved, low cost buffer, so why do we add more? How do we convince him? So we don't use SABA anymore, don't do it. You need to have some sort of ICS as in the reliever therapy. And this has been shown actually in studies. This is a landmark study, New England Journal of Medicine, 2018. 2 groups of patients, one used as needed just SABA, the other group used as needed budesonide formoterol. What happened? 64% reduced of risk of severe exacerbation. That's huge. None of them used fixed ICS. None of them used medication every day. So this also has been shown in a meta-analysis. If you convert these 4 landmark RCT studies were done over 10,000 patients, showing that using fixed dose of ICS LABA as needed only, as needed, who's not in maintenance therapy, compared to the SABA, reduced exacerbation severity by 55%, and reduced emergency visit and hospitalization by 65%. So this is a lot. How about LAMA, ditrobium? Did you treat patient with LAMA alone? Did we give Spiriva to our patient with asthma? Never. It's been associated with severe exacerbation. This is not COPD. This is asthma. They have airway inflammation. They have airway remodeling. They have type 2 inflammation. You need to give ICS. ICS is the cornerstone of treating asthma. So if you give LAMA alone, that can increase risk of exacerbation. So if you think your patient needs LAMA, at least he should be in a medium dose ICS LABA before adding LAMA, and that's in the last stage of the GINA, which is the triple inhaler therapy. So this is just to show you, when we investigate our patient, we consider every patient difficult to control, and then we go through the confirmation of the diagnosis, looking at the risk factors and modifiable risk factors, the comorbidities, and then we optimize therapy. As a family doctors or primary care health, you can refer your patient to us at any stage. If you think your patient's symptoms is not improving, is uncontrolled, refer him to us. We'll do our workup. We'll find out which one at risk of type 2 inflammation, and we might consider sometimes stepping up the therapy, and some of them will be candidate for our biological therapy. So in summary, low-dose ICS formoterol is the reliever for mild asthma, and it's the preferred strategy, and this based on studies. It reduced the risk of severe exacerbation compared to using SABA alone, reduce emergency visits and hospital admission. SABA is a reliever as an alternative strategy, less effective than track 1, especially in the early stages of the GINA of step 1 and step 2. Before considering regimen that have SABA as a reliever alone, your patient need to be adherent to a daily controller, even in a mild symptoms, which is not gonna do it. And this patient will be exposed to the risk of SABA alone because he's gonna just use his Ventolin. And LAMA shouldn't be used as a monotherapy of asthma without ICS. That has been associated with severe exacerbation, and you need to start the patient at least in medium dose ICS LABA. With that, I'm going to conclude my talk, and thank you so much for this invitation again.
Thank you so much, Dr. Ragad, for this informative, elegant presentation that was rich. And in fact, I learned a lot today from Dr. Ragad. So we'll move ahead with the third guest speaker, Dr. Faris Al-Hijaili. Dr. Faris, he's a consultant in internal medicine and sleep medicine in King Abdulaziz University in Jeddah, and he has a membership in the Saudi Society for Internal Medicine, Saudi Thoracic Society, European Respiratory Society. He has many publications, mainly in sleep disorders and obstructive sleep apnea, and he had a lot of contributions for So he had a lot of contributions in the research and in academia and teaching the family physicians. So on behalf of all the audience, Dr. Faris, I would like to thank you for being with us here today. and hope that you will enjoy this presentation as we did with the previous speakers.
يعطيكم العافية. I think I hijacked your turn, huh? It's okay. طيب. So that's your case, I guess. We're going to move on to the next presentation, another case. Here we go. Okay, yeah. Perfect. طيب, Assalamu alaikum. Good evening, everyone. Thank you for having me. It's always a pleasure to be here with you, honestly. I enjoy being with my colleagues from family medicine. I have Raghda, طبعا. I learn from you as we learn from each other every time we meet. طيب. My talk today is going to be almost opposite to Raghda's talk. She was talking a lot about track one. So I'm going to tell you that there is always two sides of the story. So there is also track two or other options that we use for management of asthma. So we have so many advancements in treatment of asthma, but we're not doing a great job, not yet at least. You don't need to show my face, so can you have a full screen? Perfect. Okay, so we still have issues with the paradox. We still have poorly controlled asthma. We have great family doctors, programs, consultants, residents, but we're still having issues with the control of asthma. And this is not applied to us only, it's actually worldwide, so we don't share the blame. Now, this is a common everyday story that comes to the clinic. A 45-year-old female patient with a history suggestive of asthma. She has the cough, the dyspnea, and the wheeze, symptoms more than 3 times per week. She is off medications, and she has no other issues or complaints, just to make it short. Now, what do I say? What do I do with this patient? So I have a few approaches. We know this is asthma. So I'm going to give the patient a prescription of inhalers, and few possible outcomes will happen. The patient will go home, take the medication, feels better, and in a week, they'll stop everything and never come to see you again. The other possible story, they'll go back home, they'll call a friend, or they will read the pamphlet and say, oh, there is a steroids in the inhaler, and they'll throw it in the garbage, excuse me. The other possible outcome, they'll take the medications, they'll feel better, and they might not come for follow-up or come for follow-up, depends. So there are so many outcomes of this story. Now we do have Gina. You're gonna see Gina everywhere. Whenever there is a talk about asthma, we're gonna talk about Gina because it's the most common, the most famous guidelines, but it's not the only guidelines. So we have the tracks that Raghda elegantly explained to you. But before we decide where should I start my patients, should I start them in step 1? Should I jump to step 3? And Danny already mentioned where to start your patients based on the symptoms. Now, we have to assess the patient's symptoms control. We have to document whenever we have the chance to do a spirometry. We have to assess the environment, the beliefs. Do I really believe that I have asthma? Because a lot of people, they say, oh, I don't have asthma. I just have a hyperreactive airways. So you have to discuss all of these issues before subjecting your patients to treatment. We all read about ACT, but how many of us really do use ACT in the clinic? We have a busy clinic, we're rushing, we are depending on our judgment. My judgment is if the patient is controlled, uncontrolled, or partially controlled. We used our experience. We don't use really an objective assessment based on the ACT or even the GINA questions, although it's very easy to do. But in reality, we don't practice it in an everyday. And I'm going to tell you why it's important. Now, you have to know that perception is something individualized. The way I perceive pain is different from you or from any other person. And that's typical to asthma. Not everyone perceives the symptoms the same way. We have the over-perception. They're going to take their inhalers 4, 5, 6 times. Whenever they say, oh, I'm not feeling well, they're going to take a puff. And we have only the opposite as well, the under-perception. I'm fine. The guy has an FEV1 of 50% and he feels fine. Whenever you ask him, do you have symptoms? I'm doing great. So we have the under-perceivers and we have the perfect patients who have the good perception and they're taking the medications as prescribed. So people are different. Even us physicians, our judgment is different from me, from Magda. If Dr. Dania saw the patient, will have a different judgment about the control. So They look at those patients, and based on the patient's assessment, do you have your asthma controlled or no? 80% of them felt that their asthma is perfectly controlled. And when they asked the physicians, 50% felt that those particular patients have controlled asthma. So there is a huge discrepancy. And when they did the actual GINA assessment of control, they found only 18% are controlled. So we have a huge gap between what we think is a control, what the patient feels is a control, and what the actual assessment feels is a control. So we need to do further, we need to do a better job in communicating with our patients, do the actual tasks of asking the regular questions to assess control. Again, I go back to the same thing, the two tracks, which one I choose. Now, if you're using the as-needed ICS formoterol, it is correct for the right patient. If you're using track 2, it's also correct for the right patient. So not every patient is different. We have to individualize the treatment. But if I'm relying solo on the way you feel about your symptoms, and we found out that perception is an issue, how am I going to depend on you to take the medications when you feel that your asthma is uncontrolled? That's the biggest issue. So for the right patient who is constantly know where they have symptoms, they use these medications as needed, those are good patients. But patients who cannot rely on their assessment, that's going to be an issue actually. So GINA tells you where to start if you have symptoms, and Dania already mentioned that in the previous slide. But also we have to remember that we have our local guidelines, which is the Saudi Initiative for Bronchial Asthma, the SINA guidelines, and it tells you based on the ACT assessment, if your ACT score is more than 20, you can go for either step 1 or step 2. So step 1, sorry. If you have 16 to 19, you go to step 2, and so on and so forth. So the ACT here helped me to have a baseline and to decide where should I start the medications for this patient. Now, there are a lot of issues that could influence control. It could be disease-related, it could be patient-related, and it could be doctor-related. So we all share the blame. I'm not going to touch base on those details. Raghda and Dania generally discuss those in details, but it could be multifactorial. That's the message here. It's not a one single thing that you should target. So what I'm trying to really talk today about, how do we being proactive in management of patients with asthma. Basically بالبلدي يعني أنا بتغدى فيه قبل ما أتعشى فيه. I want to be سباق أو أستبق الأحداث. I don't want to be a reflex reaction زي الانسولين سلايدنج سكيل في المستشفى. لما السكر يطلع نعطي له انسولين ينزل السكر. لما السكر every time we're just reacting to what's happening, and that's where the PRD approach here is a bit different from what MART approach is. The message in general, we do not want any patient who have asthma not to be on anti-inflammatory. This is the message. Do it the way you like, MART, PRD, as long as the patient is on inhaled corticosteroid, that's what we want you to do. So, unfortunately, we keep coming back to the control and the poor control. And we're not doing a good job in terms of action plan. Anna, the first one to blame, I don't do action plan. I don't know how much of family doctors really do action plan, but we don't do it much. 10% only have a valid questionnaire because, again, it depends on our judgment call here. Now, to be proactive, you need to make sure the right diagnosis. You need to determine the control objectively. You need to adjust the treatment as you go. You need to evaluate a very important aspect of adherence and inhaler technique, which takes time and effort. Every asthma clinic should have an educator, honestly, to follow these things. You need to simplify the treatment, give the patient something that they can understand. They're educated, they can understand the MART approach. If they are very simple people, just give them the simple treatment. You have to follow them up regularly to adjust their medications accordingly. Now, why do we care about assessing the control again? Because those patients from different countries, I'm not talking about just Saudi, Argentina, Brazil, and so on and so forth. They took patients with asthma and asked them about their asthma control. If you can see here, no controlled, or not controlled at all, or poorly controlled is the green and the purple color. And they represent almost 9–10% only. Everybody is happy with their asthma control, and this is across the world. These are from the patient's assessment. Despite that, the same patients, half of them, they are missing work days or school because of asthma. Half of them having more than one night symptoms per week, and almost 65% overusing their SAPA. So again, the perception of assessment or of control is not the best way to do it. This is the GINA of what you considered control or partially controlled, and this is the ACT that we just mentioned. So now we know that it is important, not just only for control. If you have an ACT score low, that means you are having a higher risk of exacerbations. Almost 33% increase in the chance of future exacerbation if your ACT score is 17. So it just helps as well to assess my future risk of exacerbations. All right, so this is the same GINA, the two different tracks. Just to make it easy, from 3 and above, most of the guidelines share the same concept. Regular, either low or medium dose of inhaled corticosteroids, plus another bronchodilator such as LABA. 3 to 5, almost all the guidelines share the same concept. The challenges is 1 and 2, the cases or the mild cases. A lot of physicians prefer to be on either PRD or MART. It depends on their training, their belief, their experience with their area, the patients that they deal with. Now, there's so many guidelines. It's not only GINA. We have the SINA. We have the SINA tells you that you can use formoterol ICS as needed, or you can use regular ICS. So they don't have the preferred and an alternative. They give you the option to choose either or. There is no preferred treatment here. This is the British guidelines. They don't mention anything about the as-needed ICS for formoterol. They want you to be on regular dose ICS if you have persistent symptoms. The Spanish guidelines as well, they don't want you to be on anything in the step 1, but they want you to be on inhaled corticosteroids once you have a step 2 and above. The French guidelines, again, they want you to be on a regular inhaled corticosteroids. There is no mentioning of the MART approach in the early stages. This is the National Heart and Lung Institute. Again, they want you to be on regular anti-inflammatory, not as needed. This is the Turkish guidelines. They share the same GINA guidelines, so they prefer the MART approach. So the message here, that there is so many guidelines, and they are not all enthusiastic about using the MRT approach. So they want you to use inhaled corticosteroids as possible. You can use the MART. It is not wrong. It's right for the right patient. So how do we summarize this, really? So remember, PRD or proactive approach, you want to have the patient on anti-inflammatory whenever is possible. Some patients, they're good using the MART, but most of our patients, they need to be on a regular dose of inhaled corticosteroid. You don't want to wait till they get the exacerbation, then you adjust accordingly. We know that asthma is an inflammatory condition. Anti-inflammatory is the cornerstone. We know that we want to have low symptoms at all if we can. We don't want any future exacerbations. So that's the goal. And the science does support all of these. And eventually, we want to reduce mortality. We want to have patients live a normal quality of life. And again, individualized medicine, precision medicine. Every patient is different. You have to individualize your treatment accordingly. You can use track 1, track 2, MART or PRD approach, select it for the right patients, and that's the message that we want to share here with you. Thank you very much, and I'll be happy to share any questions in the question session.
Thank you so much, Dr. Faris, for this elegant presentation, shedding light on the approach of proactive in the management of bronchial asthma. So now we are going to share with you a case study in bronchial asthma. This is from the real-world practice. This will be highlighted by Dr. Adania. So we will close our scientific event by this case study. Dr. Adania, please.
alaikum wa rahmatullahi wa barakatuh. Hello again. Um, Today we will discuss a simple case which can come in any primary health care center. Sarah is 41 years old, secretary. She comes to see you for evaluation of intermittent episodes of wheezing and shortness of breath that have progressed over the past 2 years. She feels that she has more colds than her workplace colleague. Each episode lasts for 2 to 3 weeks with persistent cough and dyspnea. She had wheezing and allergy symptoms in childhood, and her mother and one cousin have confirmed asthma. Over the past 6 months, she has noticed that because of her dyspnea, she is unable to do exercise. She is otherwise well and taking no medications. She smokes half pack of cigarettes per day and has done so for 20 years. A few weeks ago, Sarah's primary care physician gave her a salbutamol inhaler. In addition, he arranged spirometry for her, both before and after administration of bronchodilator. She reports that she has been using the salbutamol nearly every day for dyspnea and when she wakens during the night with similar symptoms. The latter is still a weekly occurrence. Her spirometry results showed FEV1 of 78% of predicted, FVC 99% of predicted, and FEV1 over FVC ratio is 66%. After administration of inhaled bronchodilator, there was 17% improvement in FEV1. So our case showed mild obstructive defect because of the FEV1 is more than 70. You make the diagnosis of asthma. What's your proposed management? I didn't dig more in the history and the examination and the approach because we already discussed these items before. So our patient is regarding to her symptoms, which are symptoms most days and once weekly awakening during sleep. So the patient is at step 3, and we should choose one of these tracks for her. And sure, the preferred track will be track 1 is low dose ICS formoterol maintenance and reliever, which is SMART therapy. Each patient comes in our primary health care center. We should assess and adjust and review his management cycle by confirmation of the diagnosis if necessary, and assessment of symptom control and modifiable risk factors, and comorbidities, inhaler technique and adherence, and patient preferences and goals, and adjustment of treatment and comorbidities, non-pharmacological strategies, and asthma medications, and review of symptoms, exacerbation and side effects, lung function, and patient satisfaction. Patient education is very important. Patients who are involved in the management of their asthma tend to have less time off work and fewer hospitalizations. Patient and caregiver issues. There are some questions that also always asked by the patients and their caregivers. The first question is, will I become dependent on inhaled corticosteroids? The answer is no. Other question is, should I limit my exercise? The answer is no. Will controlled asthma by using of modern treatment should allow you to perform your activity? The other question is, when should I go to the emergency department? If the patient has the peak expiratory flow meter at home, when he sees the red zone, he should go immediately to the ER, and the yellow zone, he should go to the ER as soon as possible or seeking medical care. Other question is, when should I stay off work? Generally, when your peak expiratory flow is within 20% of normal and you are not symptomatic, you can go to work. Once a stepwise treatment plan has been established, follow-up of the patient is required. Why? To check on treatment compliance and tolerance, review asthma symptoms, review peak flow rate diary, check whether patient's goals have been achieved. There are some clinical peers which are important for any physician. To tell the patient, new onset asthma may occur at any decade. Like other patients, she is 41 years old. Individuals with pronounced airway hyperresponsiveness may be at increased risk of progression to chronic airway obstruction. Even elderly patients may present with new onset asthma. The diagnosis in these individuals is sometimes overlooked in favor of other chronic diseases of the elderly. Asthma may present solely as chronic cough. Documentation of airway obstruction or hyperresponsiveness is crucial for diagnosis and effective therapy. Chronic sinusitis is a common accompanying disorder that can greatly influence asthmatic condition, and the medical or surgical treatment of chronic sinusitis often result in dramatic improvement in the patient's asthma. Patients often do not use their metered dose inhaler correctly unless they are repeatedly instructed on the proper technique. Because of that, we should tell the patient in every visit about the technique and make sure that they use it correctly. What are the indications of referral? First of all, if the patient has difficulty confirming the diagnosis of asthma, patient has symptoms of chronic infection or features suggesting cardiac or other non-pulmonary causes, should have immediate referral to the specialized physician. If the patient has suspected occupational asthma, persistent or severely uncontrolled asthma, or frequent exacerbations, any risk factors for asthma-related death, any evidence of or risk of significant treatment side effects, and symptoms suggesting compliance or subtypes of asthma, like aspirin exacerbated respiratory disease or allergic bronchopulmonary aspergillosis. This is a simple question at the end of my presentation. Which of the following patients is a candidate for as needed ICS LABA therapy? Anyone know the answer? That's right. Thank you so much.
Okay, thank you so much, Dr. Dania. Now, coming to the end of this session, I would like to invite all the guest speakers to be coming on the stage here for Q&A session. تفضلوا. دكتور فارس, دكتور رغد, دكتور دانيا. As we have an online attendees and we have some of the questions, but I will give the preference and the privilege for those who are attending physically to give us their own questions to start with. So I will open the floor now for the audience. Any question from the Ahmed? Questions? Okay, we have here. Why is that working?
Thank you very much. I think we are getting a little bit of high mood because if R1 will come, with this presentation, I think it's beautiful. I think we are improving, and as well, we are minimizing the gap. As well, primary care, which is, I consider it as inclusive medicine, because you are absorbing and minimize the care, minimize the burden of all those things. I think this is another, which is a narrow gap in the future.
Thank you.
I'm not going, to go for further, but I think for bronchial asthma, and until now we have this kind of suboptimal control. I think what we need, I think, to use the AI, for instance, in a different way to attract and to reach all those patients before anything will happen, and to get our national analysis for our genetic, how to improve the system here. It might be taking a long time, but I think this is what we have to do. I love to hear from the speakers some more input. Thank you.
Okay, I think I would like to forward this question to Dr. Dania. Dr. Dania, why asthma from our own practice as a family physician is still suboptimally controlled, and still we are seeing more severe asthma cases growing up? So where do you think the problem? In fact, it's a multifactorial. There is patient factors, there is physician factors, there's healthcare system factors, and all these are contributing together. So from your own perspective, what do you think?
I think, first of all, our role as a physician is to educate the patient about the use of inhaler, especially if the patient is newly diagnosed and has no idea about his diagnosis. In our busy clinic, we don't have time to educate the patient, and sometimes the patient take the inhaler and don't use it at home. So it's our part of education of the patient, and we should have time to educate them correctly.
Thank you. Any additions, Dr. Faris?
Yeah, I think, as you said, multifactorial reason why we still have suboptimal control of the asthma. As we all seen by Faris' talk, some of them has related to the doctor, some of them it's related to the patient, and some of them related also to other factors. So one of the biggest thing, I think, that the diagnosis of the asthma is not easy to make. As long as it's people present with wheezing and all that, it's not easy to diagnose the asthma. We don't always get the reversibility testing. And again, the teaching about that. I have noticed that majority of our patients referred to us from family physician or referred from Emerge or other subspecialty to our clinic, they don't actually know that they have asthma. Why? They don't like the term asthma. If you tell them, are you asthmatic? The first thing, no.
Stigma.
حساسية في الشعب الهوائي. I lost the battle, خلاص, not anymore. Okay, whatever. You don't have the asthma. So the teaching and the education is a big deal in these patients. If you don't convince them they have a chronic condition as chronic as diabetes, hypertension, they're not going to convince to take their buffers and inhaler. And again, let's go to compliance issue, adherence issue, using the proper treatment, assessing the control, over perceptions of control of the disease, under perception, as Faris mentioned, about the severity of the symptoms. This is all multifactorial reasons why your patient is suboptimally controlled.
Excellent. So Faris?
Yeah, I can't have much to add. Problem with our asthma, let's say, they don't take it seriously. If they're treating it or respecting it like any other chronic disease, it's hypertension. You take the pills, it doesn't give you any feelings, it doesn't give any relief of symptoms. But because people are scared of hypertension and they know it's a chronic disease, they take it, but inhalers, they don't take it as serious. This is, I think, we have a huge gap in terms of education. We're not doing a great job yet in terms of education.
Okay, let me highlight from my own perspective. I'm encountering a lot of agony controlling asthma in my practice, and I think there are three different domains that we can talk. Patient factors, that's why our patients, they are not understanding that asthma is a serious disease, and using the SABA might lead them to mortality. As the more canisters, the more mortality and death happens, as we have seen in the studies. So they are not perceiving the disease as it is, and they're not proactive in order to be an active partner with a physician to make the management plan according to the guidelines and according to the instructions of the physician. So that's why we have to have a community awareness to elevate this kind of perception from the phys. When we go to second level, which is the physicians, we demonstrate a clinical inertia. We are not proactive, as you said, Dr. Faris. So that's why clinical inertia is the failure of a physician to start or to up-titrate or to combine medications for a patient that is required for the patient according to the guidelines, and the patient is willing, but the physician is failing. So this is why we are not proactive. So that's why, although we are a family physician or even some other specialties, they are not considering this. One of the things that is going back again to the patient perception, they don't want us to label them as a bronchial asthma patient. بيقولوا لا عندنا حساسية في الصدر, but that's it. حساسية, it's not a bronchial asthma. So, and the moment they understand that they have ICS or cortisone, they just drop it and they fail the whole. And the third one is the healthcare system. If you don't have a clinical guideline that can be applied across the board in primary care, secondary care, within the hospitals, definitely we're not speaking the same language of medicine. The patient will have some kind of turbulence going through these different levels of practice within the one organization. So to govern the practice and the quality. And now, ladies and gentlemen, we're talking about the value-based healthcare. So multidisciplinary team approach for bronchial asthma is very important. As I said, it's not only physician who treating asthma, it's also educators, psychologists, and others. And it will be a patient-centric approach. So one size is not fit for all. So that's why we have to look into the patient as a valuable patient, that he has to have his own way of management. And then we have to follow up the guidelines, and we have to look into the outcome of what we do. So having KPIs and we're having certain targets to be achieved is very important. And then at the end of the day, we have to be cost effective, not to exhaust our resources. So this is my just highlight. There is a very interesting question, Dr. Ragad, Dr. Faris. During the COVID, we have witnessed hyperactive airway disease or incremental increase in the bronchial asthma. And there was a lot of people are using ICS and SABA, LAMA, and others, in fact. What is your comment on this?
During the COVID era and until now, after after it's been called it's not an emergency anymore and COVID is almost going, we are seeing a lot of patients, they report symptoms of asthma post-viral infection and wheezing. Whether these people have asthma before and the virus actually triggered the asthma, or whether these people having post-viral just new diagnosis of reactive airway disease, sometimes it's difficult to make. However, a lot of them, they have experienced wheezing, chest tightness, shortness of breath, symptoms of asthma, more recurrent after the virus or becoming more severe that they need to be on ICS. It's not just, and most of them, they are in ICS LABA. It's not just mild asthma. Some of them, they have recurrent symptoms. So we have seen the virus actually caused a lot of patients to present later on with reactive airway disease. I'm not sure whether, as I said, the virus triggered the symptoms or just the patient did not have previously had milder symptoms and now with the virus is having more severe symptoms, but we're treating them like asthma. We optimize them. We go through the same algorithm. We go through the same treatment plans. And then some of them we have noticed, and I'm sure Faris, you might agree on this, that after 2 years from the exposure of the COVID, they might actually go back to their pre-COVID state.
Okay, perfect. Okay.
I can't add much. We don't know why. It's been observed, not just in our region, it's worldwide. We don't know. It could be related to just a simple viral illness that precipitate the whole cascade of events, but we don't know for sure what's the pathophysiology behind it.
Okay. طيب, Dr. Faris, from family medicine perspective, do you think that we should be confined to track 1 and we should not go to track 2?
Oh, absolutely no.
Okay.
This is, you mentioned earlier, this is our bread and butter as family medicine. I totally agree with you. You should do, with every individual, you treat them differently. You know that from the patients that you're seeing, that they are the ones that you need to instruct them of exactly what to do. 1 + 1 equals 2. And some of them, they like to be shared in the decision, and they can have the power to trust them in deciding what symptoms do you have, and you trigger the medications accordingly. So no, absolutely, you are free to use either track.
The risk of using SABA in track 2.
Yeah,
how to control it.
Even track 2, nobody wants anybody to take SABA without ICS, even with track 2. You can say the same in track 1. Okay, if I'm depending on your perception, as we said earlier, most of them, they don't have a good perception.
Absolutely.
the message that how many of our patients needs to be on step one, really. By the time they present to your clinic, they already have significant symptoms. So the chances that you see a patient in the clinic at an initial assessment that they are required to be on step one is unlikely. Maybe during follow-up, and by that time you already establish the relationship, you educate the patient about the pathophysiology, the chronicity of the problem. Now, I'm upgrading you, you're doing great. Let's upgrade you to as needed medications. So the story is usually different because they don't present unless they have symptoms.
Excellent.
I just have a comment on this. So when the GINA said track one is preferable track, because just if they're afraid that people will use SABA alone, that's it. Especially in the early, step one, step two, that's it. Because in step one and step two, if your patient, as I said, doesn't have a good adherence and compliance, he will use SABA alone, that's it. But for example, the patient that Dania presented, he was on almost step 3 symptoms, daily symptoms, awakening at night. Is that patient we have to use track one? Absolutely no. He can be on MART, ICS/LABA as needed, and low dose as maintenance therapy. And I can be also in fixed dose ICS/LABA already with some SABA as needed. So from step 3 and going up, I think it's just patient-centered assessment based on, because there is some of our patients, they come to us and they already love the Ventolin, and again, if you give them the Symbicort, they might not use it. So we need just to convince them that they need to use ICS/LABA with it. So Ralvar, Seretide, whatever other non-budesonide formoterol treatment. So the preferred GINA guidelines were just because of the concern of using SABA alone. So this is why it needs to be patient-centered, individualized, and again, it's not just one decision from the physician. It's coming with discussion with your patient and see what your patient prefer, and then we'll go from there. Because if your patient leave your clinic not convinced, he will go back to use SABA alone.
Excellent. Dr. Faris, management of the unperceivers, we have seen here elegantly in your presentation, there is a gap of perception between the physicians and the patient in the definitions of control of asthma. So how to bridge the gap in between these two perceptions?
Okay, I think from a physician aspect, we need to start using an objective tools for assessment, validated questionnaires. And the more we're using it, patients will be familiar with it. Those are the questions they kept. Every time I visit you, doctor, you ask me the same questions. After 2, 3, 4 visits, I'm gonna know exactly what you're looking for. Then I'll be coming, oh, I noticed that last few months, I've been having a lot of nighttime symptoms. So they will learn as we practice it more and more. So, and we have to practice it, honestly. It doesn't take time. The more you do it, it's just an automatic thing. We can actually give it to the patient. It's a self-administered questionnaires, by the way. So in the waiting area, especially if you have an asthma dedicated clinic, which is not the case realistically, but they have to fill it, they can fill it themselves, and they come to you ready with the actual results. So I think that's one way of looking at it. I don't know if anyone has any bright idea.
Yeah,
but that's how we look at it.
I think this is a very good idea, and usually we use our nursing colleagues in the triaging area to give the patient this kind of questionnaires, not only for bronchial asthma, but also for any other disease. And this is a checkpoint where we are utilizing the availability and encounter between the nurse and the patient. And we count that interactions as the 5th or the 6th vital signs to be taken by giving the questionnaire. So we pick up those cases.
And it kills the waiting, by the way.
Absolutely. Engagement of the patients, yeah. Dr. Ragad, we heard a lot about the GINA. How about the SINA? And what is the difference between the GINA and SINA? The current, any customizations based on our own community profile has been adapted in the SINA that we could follow? Or we just go ahead with the GINA, that's it, all what we have to consider?
We follow the GINA, it's the global thing, but the SINA also, it's the adapted from the GINA. So as far as I know, and I leave Faris to answer this, there is not a lot of difference between the two. They're basically the same adapted guidelines, it just...
They're more or less the same. They don't have the 2 tracks, however. Yeah. They just lump sum everything in one. They're giving you the 2 options in step 1 and 2. From the ongoing, they're the same. Okay. But more or less, there is no major difference.
Major difference.
Okay. Any questions from the audience before I ask the $1 million question for the audience? دكتور تفضل. That will be the end.
Assalamu alaikum. I'm Dr. Omar,
Dr. Omar
Shamma, a pulmonologist. Thank you, Dr. Adania, Dr. Raghda, Dr. Faris, for very nice presentations. A question about how do you see the role of the relationship, the ideal relationship between family medicine physician or internal medicine from one side and the specialist pulmonologist from other side? Dr. Raghda in her lecture alluded to some of the indications for referral, but I'm asking from a practical point of view, especially considering the culture of our patient population. Some patients expect to see a pulmonologist right away once they hear a diagnosis of asthma. So do you tell these patients that you're referring them to a pulmonologist for a one-time visit to discuss the ideal treatment and they come back, or how do you see the ideal relationship?
Dr. Omar, you have taken half of the millions now. This is half of
500,000.
million.
Okay, good.
So yes, Dani in her talk did talk about the indications for referring patients to pulmonologists. For example, having uncontrolled symptoms, severe symptoms, near fatal exacerbation, poor lung function, and suspecting comorbidities like allergic bronchopulmonary aspergillosis and different. I guess the thing is, we need to speak the same language to our patient. We need all to speak as family doctors, internists, pulmonologists, the same language to our patient. And then as a pulmonologist, if you see a patient in your clinic and we can understand some of these severe cases, they can come to the primary care or the family doctors to start. And I think it's the first thing, establishing a diagnosis, starting the treatment, and then we are happy to see these people in our clinic, to do our assessment, and then establishing a relationship. And some of these people are actually, they are going to be needing step up and more than just an ISIS-LABA, where they need to follow with the pulmonologist. But at the same time, we do our assessment, and sometimes we bring these patients back to the family physician as we discussed everything. We reassured the patient, we did lung function, we ruled out comorbidities, we assessed you for type 2 inflammation asthma, everything looks fine, and now you can carry on with your family doctor. So if a patient requested to see the pulmonologist early on, that's fine. Just send them to the pulmonologist who will assess them and see them and deal with them, and then we will discharge them for our clinic to continue to follow up with their family doctors and with their internists. So I don't think even in some of the GINA, they said there is no wrong to refer the patient at any time to see the pulmonologist, even at least once.
Excellent.
I don't know if you Faris have other opinion.
طيب relationship بكل بساطة, if you don't have friends in family medicine, you will be out of work. That's what's going to be the case in the future. Have to have a good relationship with Dr. Ashraf, with everyone, so they can refer patients to me. That's what happens everywhere. أنا ورغدة لما رحنا, first thing that we did, we looked for a family doctor. Then we cannot do anything without a family doctor.
Okay.
That's number one. Relationship has to be bi-direction. So I have a question, they can send the patient anytime, and once I'm happy with the answer, I send the patient back. What we need to really work on is ثقافة الناس, the culture of people, that these are your primary initial doctors. The visits and everything starts from there. They move the chess, everything they move through the family doctor. You don't have the power to go and see a specialist immediately because you don't have the knowledge. Go see your doctor, they will tell you where to go. Because in my clinic, I see a lot of patients that they should not be in my clinic. They should be in an ENT, or they should be in allergy immunology clinic. So I think culture needs to change, and it looks like the future is going that direction.
Yeah, thank you so much, Dr. Faris. And I would like to thank Dr. Omar because this actually was my question, but the other part of it was Dr. Raghad and Dr. Faris, how do you perceive and how do you look into the quality of referral that you receive it from family physicians? Is it justified, or you have certain comments on it? Because we have clearly defined to the red line after which we should not cross it as a family physician, and this will be the area where we have to refer patient to you. So give us your insight.
Okay. So one of the things that I think made our clinic, as Faris said, that we see a lot of patients that not proper referral because patients do self-referral. They just book an appointment with us and they come. And again, We end up referring these people to other subspecialty, not back to the family medicine, other subspecialty. For me, most of my patients that in my clinic, they have comorbidities, I always refer them back to a family physician. Even if I want to carry on the care, the management of the patient, but I refer them because they have other comorbidities that I want the family doctor to take over. And again, I want to increase that thaqafa, and you have to have your family doctors to go back to check and to have a primary healthcare physician like taking care of all of your medical issues and then referring you to the right subspecialty. The referral I get from the family doctors where we work, let's example in the IMC, is not as much as the self-referral that I receive from the patient themselves. So if I get referral from the family doctors, usually because patient requested to see us, number one. Number two, some of them refer them to us because they want us to do lung function test. So they refer them to us to order the lung function and do the lung and read the lung function. And some of them, I get them from the family doctors to control the asthma. But I don't think still we have this proper referral pathway that I receive the referral to the pulmonologist, for example, to the head of the pulmonologist with questions clearly from the family doctors. I don't think we still have this. It's not as clear as we were in North America. Your family doctors will send you a specific question to this patient. I want this or I want that. It's not just here I feel more, it's more of patient preference. He wants to see the pulmonologist, or we need to do lung function, or it's a self-referral min al-marid.
Yeah, but I think with the new system that we are going to adapt as a primary care will be the gatekeeper of the healthcare system and the first contact with patient under the governance of the CHI. The preference of the patient will be deleted, and it will be a purely scientific decision has to be taken by the physician who is a primary care. Dr. Raghad, Dr. Faris, just to close the session by, if there is only one single advice, I would like you to give it as one single statement for family physician. What will you say from your own perspective?
That's a very tough question.
That's a tough question.
I think just deliver the message that it is a chronic condition. You're not supposed to stop the medications in 2 weeks. This is the main reason for multiple visits is people stop medications. So it's just the message that we need to deliver. I mean, the education part. From your aspect and from our aspect, we have to spend so much effort, time. We're not doing a great job in terms of educating the patients about the condition itself. And that's hunting us later down the road because we're not spending enough time with them, we're not educating them enough, and they end up having an uncontrolled asthma. I think education is the issue that we all fall short.
Excellent.
I was going to say the same thing. Education about the disease, education about the chronicity of the illness, education about the risk factor, education about the puffer technique, education about this medication is not medication to stop after you feel good. This is, I think, where the gap is. I think we sometimes rely on each other. I would say the family medicine will do it. The family medicine will say the pulmonologist will do it. I think we should share the responsibility into educating our patient because we see it. We see these people stopping their medication, coming in our land, in our emergency department in a near fatal asthma exacerbation.
Okay, ladies and gentlemen, dear colleagues, on your behalf and behalf of all the attendees online, I would like to thank our guest speaker, Dr. Faris Al-Hijeri, Dr. Raghad Arif, Dr. Adania Khalil for the wonderful contribution for the success of this wonderful session, which was quite rich. And I think we have put the salient points regarding the major components of excellency in managing patients with asthma. And I would like to extend our thanks to all of you for attending these sessions. A special thanks for GSK for sponsoring this. And I would like to thank them because they are always motivating us to have this wonderful gathering in order to look into these kind of pitfalls and clinical pearls that we can share by having the expertise with us. So I would like to thank also the Saudi Society for Family and Community Medicine because they are our partner. Thank for Multaqa Al-Khibrat for organizing these sessions, and I would wish you a very successful practice in the management of bronchial asthma patients. With this, I would like to remind you that next month we are going to have another session, different topics. That's why family medicine, the diversity of the different topics that we have it in family medicine make our gathering more interesting for all of us. Thank you very much and have a wonderful night. The dinner will be closed to the next room, I believe, here. So please give us the joys of having your company in our dinner. Thank you.
you.